got this right.
So bicuspid valve repair and our understanding of bicuspid valve pathology goes centuries back, where it was first described 500 years ago by Da Vinci. And in the early part of the 20th century, Dr. Abbott first recognized that a BAV anatomy was associated with aortopathy in terms of dissection, coarctation, and thoracic aneurysms. Our current understanding of BAV pathology is related to the fact that several in the 1970s and 1980s, studies clearly confirmed associated with dissection, and our current imaging and clinical studies clearly demonstrate complications in terms of both valve dysfunction and proximal aortic dilation. And there is current recognition that BAV is now a valvuloaortic pathologic condition in adults. This was a paper published in the 1958 using circumclusion, a suture ligature at the base of the aortic valve, probably at the level of the BAJ, in reducing annular diameter in order to achieve valve competency. Later on, Cabral described the subcommercial plication, and then in the 1990s at the Cleveland Clinic, BAV repair by free margin plication and triangle plication of the valve was also described. So where are we today? Well, recently, over the last decade or so, or really 2 to 3 decades, we've taken lessons from mitral valve repair and categorized AI. We've understood better the anatomy of the aortic valve and the root complex and the critical components that are needed for valve competency. We understand the importance of cusp configuration, and then we've classified BAV anatomy both in terms of phenotype and what's repairable, and we've correlated root and cusp anatomy to valve function. And because of that work, in both the AHA-ACC guidelines as well as the European guidelines, BAV repair is now considered a 2B indication in the appropriate anatomic setting and in selected patients. The current challenges to bicuspid valve repair are the complex interactions that exist between anatomy and valve function. It's easier to replace than repair. Long-term data are still difficult to judge, and there are a lot of different techniques among surgeons, and all of whom are leading experts, and lack of uniformity leading to potential confusion and controversy. So if you think about all the options, we've got reimplantation versus remodel. We've all heard these terms: annuloplasty, no annuloplasty, single annuloplasty, double annuloplasty, root repair, root replacement. I mean, it's easy not to get confused here, quite honestly. So what do we really know here? Well, we know that BAV repair requires addressing 2 things: cusp disease and the functional aortic annulus and root complex, sometimes just the ascending aorta alone. Anatomy matters, and that leaving the patient with ongoing STJ dilation, VAJ dilation, will render any isolated cusp repair ineffective. So this is how I like to think of BAV repair and addressing AI. These are my broad categories. See, I think you've got to alter aortic root geometry, which is annuloplasty, where you orient the commissures, doing a valve sparing root replacement or a concomitant aortic replacement, and then there's cusp repair. And typically that's addressing cusp prolapse, which for me is free margin plication and occasionally wedge or resection of the median raphe. The Gore-Tex suture weave, which was described by Dr. David several decades ago, is not really used as much, at least in my knowledge, BAV cusp repair, because those valve cusps are typically not thin and frail. So let's clear the air a little bit here. So this is a paper by 2 of the leading experts in Europe, and they took the anatomy of the root, they took the anatomy that the patient presented in the setting AI and kind of categorized what operations are important. So if you've got so starting on the left, if you've got a normal annulus, then you can just do subcommercial annuloplasty. If you've got a dilated annulus, you may need to do a double annuloplasty. If you've got a dilated root, you can do a number of things: reimplantation, remodeling, and if you have a dilated ascending aorta, you can do annuloplasty or an ascending replacement. So they categorize the different techniques based on pathologic condition of the patient. This, I think we all know this, this paper. this category from Dr. Sievers, where he categorized bicuspid valves in type 0 or type 1 and type 2, which is essentially a unicuspid valve. And then ultimately, the group from Belgium took that anatomy and then, based on the original anatomy, then determined what the appropriate repair techniques were based on normal cusp of annular dilation, cusp prolapse, or cusp restriction. And I think recently there's an international consensus that was published which took the original Sievers categorized and made the sort of stretched out the spectrum. So you've got on the one far right a true bicuspid valve, Sievers type 0, and then you go to the far left, you got what looks like a trileaflet valve to most cardiologists and most cardiac anesthesiologists, but really you've got this partial fusion, this formed fused ATAS, which is truly which is just a bicuspid valve that kind of wanted to be but couldn't quite decide. And then in the middle of that spectrum, you have what is the classic Sievers categorization of Sievers 1, but they took the commissural orientation and further categorized it into symmetric, asymmetric, very asymmetric, or symmetric with no RAF-A. And this is just what this is a Sievers 1, and again, 70% of those are Sievers 1 left with right-left fusion, and you can see the percentages of the other anatomic variants. And then later on, this same international consensus also distinguished various phenotypes of BAV aortopathy, where you have the ascending phenotype, the extended phenotype, or the root phenotype as a way to further categorize the anatomic pathologic conditions. So when you think about the anatomy of the valve and the root and the implication of valve repair, we've seen this earlier in the earlier sessions. The valve root complex is the SCJ, where the cusps attach, the VAJ, and the virtual basal ring, and ultimately these and then of course on the right here you've got the geometric height and the effective height of cusp coaptation. But all these components can be changed in various pathologic conditions, such, for instance, here you've got a trileaflet valve with symmetrical heights of the commissures, and then when you have a bicuspid valve, one commissure height is a little bit lower, and then a unicuspid valve, and so the anatomic components of this complex change based on the pathology. And then there was another study that looked at various components, including geometric height, virtual basal ring, and STJ, and you can see that as the geometric height of the valve increases, there's better coaptation, but as the virtual basal ring and the STJ increase, there's less coaptation and more risk of valve insufficiency. So the VAJ is this transition point from the muscle to the aortic wall. It is not planar, and then the distance is much larger than in trileaflet. In the BAV valves, it's much larger than a tricuspid valve. So I think that as this understanding of anatomy took place, then people began to understand the determinants of what would constitute a good repair. So the anatomy that really determines a good repair are your cusp configuration and size, how much your annulus is dilated, where your commissures are oriented, and whether there's valve degeneration requiring some debridement and pericardial patch reconstruction. So the critical components of any successful repair are how you repair the cusp, what you leave the root geometry like, whether you do an annuloplasty, and whether you need a concomitant root ascending replacement. So here's a couple of things that I've sort of realized in my doing these operations. In bicuspid valve, to achieve a bicuspid valve that's competent, there's only one line of coaptation that's responsible for maintaining adequate valve function. Cusp repair is mostly focused on the conjoined cusp, not the independent non-coronary cusp in the Sievers type 1 with left-right fusion. The post associated with that RAF-A, the conjoined cusp, is essentially irrelevant in my mind for valve competency. Later on, taking some of that international consensus statement, our Belgian or really our European colleagues categorized repair difficulty based on anatomy of the symmetry of the commissure orientation, such that the most difficult one is the very asymmetric type C, whereas the type A was relatively more straightforward. And so, we then gained an understanding that valve configuration does determine the long-term results, such that predictors for reoperation from the Schaefer's group, which is a group that advocates the remodeling technique, effective height, aortoventricular diameter, the orientation of the commissure, and the need for pericardial patch, all of those things are determinants of valve durability after repair, and that it can be reconstruction can be reproduced with good results, but recurrence and progression of AI can occur, depending on the initial anatomic features of the valve. So here are some of those data. So if the initial commissural orientation was less than 160, i.e. a very asymmetric valve, those valves are more likely to not do as well in long-term follow-up. Same as if the effective height of the initial valve was over 9 millimeters, that was a much durable valve compared to those that were less than 9 millimeters. Same, if you needed a pericardial patch, those valves often fail within about 6 years. And if the original AV diameter was over 29 millimeters, those valves were not as durable as those that had less of annual aortic dilation. And if you did have a dilated annulus, if you did a subcommissural annuloplasty, you were more likely to have a durable valve. And if you had a dilated annulus, you were more likely to do better if you did remodeling as opposed to not doing a root replacement operation. This is some data from the Penn group, and ultimately it's saying that stabilizing the root with subcommissural annuloplasty or valve root replacement, relatively the same, but the root replacement patients did have a lower incidence of over mild or over 1+ AI compared to subcommissural annuloplasty. And they looked at predictors of why valves would have AI after a repair. This was ultimately the bottom row. They had 3 separate operations depending on the annulus. If your annulus was your initial annulus was over 28 millimeters, you had a valve sparing or a valve repair with external subannular aortic ring. If you had less than 27, you had either subcommissural annuloplasty or the external ring. And the only thing that proved to recur AI was the presence of a greater, or it was subcommissural annuloplasty done in the setting of initial baseline diameter over 30 millimeters. Everything else did not prove to be predictive of over or equal to 2+ AI. And this was another study where they further confirmed that the external subannular ring was a more durable repair procedure than doing subcommissural annuloplasty. So when you think about annuloplasty, you've got subcommissural annuloplasty, intraannular rings, external rings, all these various techniques. And the problem is that it's hard to judge all this because there's a lack of control group. Everyone's kind of doing what they're comfortable with, and a lack of many confounding factors. This particular study looked at mechanisms of recurrent AI after valve repair. So ultimately, people that had valve repair, 244 patients with severe AI, they included 186 patients, and of those 186 that were included in the study, 41 had severe AI, of which 23 had redos. And then they ultimately showed, based on statistical analysis, that coaptation length, the presence of billowing, the valve being below the level of the aortic annulus, the diameter of the annulus, and leaving the OR with residual AI were predictive of recurrent, moderate, severe, or higher AI in subsequent follow-up. So, so despite these concerns, the data are good. This is the Hanover group from Dr. Schaefer's, and he primarily did BAV repair root remodeling and showed that the cumulative index of death and reoperation relatively low. There was on the right graph, there's a higher incidence of over mild AI, but over moderate AI and death relatively low overall in his series. This is the Brussels group, which did mostly reimplantation. And again, whether it's a trileaflet valve or bicuspid valve, your percentage of risk of AI or death was relatively low at, at long-term follow-up. Dr. Lansec in France has advocated recently the use of a double annuloplasty and compared it to single annuloplasty, and he showed that your risk cumulative index of death versus a valve reintervention, a redo root, and major adverse cardiac events were all much better with a double annuloplasty than with a single annuloplasty. So, but how much AI is too much AI? I think we looked at this in our group and ultimately concluded that almost any bicuspid valve, in the absence of any calcified degeneration of the cusp or sclerosis, can be repaired, no matter how severe. But you have to be mindful of creating iatrogenic stenosis by narrowing the annulus too much without significant root enlargement. And the other thing that we looked at recently was, does jet centricity matter? We took all our patients that over a long period of time that had a valve sparing that had over 2+ AI and divided them into a bicuspid group, trileaflet group, eccentric and central AI. And we've shown that typically in a bicuspid valve, most patients have an eccentric jet, whereas in trileaflet it was sort of half and half. But whether you had a bicuspid valve or eccentric AI, there was no real difference if done correctly, of course, and we'd like to think we did it correctly. The incidence of recurrent AI or the need for AVR was not much different with a trileaflet valve compared to bicuspid or eccentric versus central AI to begin with. And so, when you think about bicuspid valve, AI and doing a valve sparing, there's sort of 4 categories based on valve morphology and jet centricity that are increasing levels of difficulty. So a trileaflet valve with central AI, usually doing the valve sparing is enough because the AI is related to lack of coaptation from the aneurysmal enlargement. Not very common for a BAV valve to have central AI, but typically doing a valve sparing, plus or minus maybe a little cusp repair is required. A bicuspid valve with eccentric AI, you only have one line of coaptation to consider, and that's a little more complicated than a central jet. And ultimately, the most complicated one is a trileaflet valve with eccentric AI, because you got 3 lines of coaptation to consider, and it usually requires a cusp repair. So in terms of long-term data, does support aortic valve repair being a reproducible alternative to AVR, but the issues with the data are there's multiple techniques being compared, lack of control of confounding predictors, lack of standard definitions, although that's getting better, inconsistent published endpoints. And really, if we're talking about young people, we don't need to be talking about 5 or 10 years. We need to be thinking about 15, 20, 25 years plus, because of how young the patients are when they're affected, and better control of some confounding factors. So I think there's been a lot of progress made in BAV repair with respect to categorizing the pathological states of aortopathy and valve dysfunction, and how we correlate valve function with certain anatomic features, demonstrating reproducibility in multiple different surgical techniques. However, real long-term follow-up and educating our younger learners is certainly critical to the future of this particular area of cardiac surgery. Thank you.
Questions from the floor? Excellent overview. Thank you very much. You mentioned the annuloplasty by using an external ring or Gore-Tex suture 2 or whatever. So the technique I use is an internal annuloplasty by bringing out the suture in the trigon left to none, and then tying the suture over a Hager dilator, which is brought into the alveoli. What is your opinion about this? Have you tried this?
I've never tried it, and I'm a little afraid to. There is this valve repair ring, this heart ring that's in the United States, but I worry that ultimately it would stretch more, and that the internal ring would sort of be torn away from that. And for me, it feels like if we're worried about sort of a radially outward pressure to dilate or whatnot, that the external ring would keep that more stable. But again, I don't have experience to say one way or the other. I just sort of thinking about it from my own experience with the other techniques.
Okay, thank you.
Yeah, it's a great presentation. And from your experience and you're studying the literature, everybody focus on the AI of the BAV repair. I found out when you do BAV repair, actually you can create the aortic stenosis, and also BAV patients congenitally or genetically have well-developed aortic stenosis because of the valve calcification. Do you see any data about the aortic stenosis of the BAV repair?
I mean, admittedly, there's a learning curve to this. So in the beginning, I would probably overcorrect the annular enlargement and I would probably overdo the narrowing of it by the graft I chose and how much I'd narrow the annulus. And then we would leave the OR, gradients in the 15 millimeter range. I've learned over the years, how to correlate what the graft diameter should be and what that ultimately results in the actual true annulus diameter, what you can put the sizer through, and so I've been a little less aggressive, and we're leaving the OR with single digit gradients. I think the other thing too is that some of these valves look really pristine, but others are pretty sclerotic, even though they still move pretty well. And admittedly, we've operated on a few patients, even including about 3 weeks ago or so, that had some, the guy was 43 at the time. He had sclerotic valve. We did a valve sparing route. He left the OR with a good gradient. His valve leaflets completely calcified and were stuck in a severely stenotic position. And so we operated him 10 years later. Was that wrong? Maybe it could be wrong if we had a mechanical valve, but he did not want Coumadin. And so we gave him 10 more years with his native valve. So I think that's okay too. It's difficult, because, you're talking about age versus valve quality. And I know over the years, the older someone is now, the better the valve has to look for me to want to spare it. But I do think very important, as you point out, to be mindful of not narrowing the annulus too much to creating iatrogenic stenosis.
Thanks very much, Ed.